Hello, everybody. My name is Rodrigo Estévez-Loureiro. I am an interventional cardiologist from University Hospital Alvaro Cunqueiro in Vigo, Spain. And I will answer some questions about the IREMMI registry, that is the International Registry of MitraClip in acute mitral regurgitation following myocardial infarction. And we discuss a little bit the results of this presentation in the TCT that was entitled the outcomes of patients undergoing percutaneous mitral valve repair in acute MR after myocardial infarction, comparing those patients with and without cardiogenic shock. So the background of the study is that we have this clinical scenario that is acute mitral regurgitation following myocardial infarction. This is can be a common issue after a myocardial infarction that is associated with high mortality. When you leave it alone, mortality may be as high as 50%. And in my account, this complication in approximately 3% of myocardial infarctions, and in 10% is a little bit more frequent in those presenting with hemodynamic instability. And we know that so far, until last year's, the only available treatment was surgical correction of this defect that usually goes with a mitral valve replacement, and we know that is associated as well with high mortality. So since there are a lot of patients that are not good surgical candidates because they are high risk, and since surgery, even when it's perfectly done, has high mortality because of the context of the patient, then we thought we can try to find a less invasive solution for these patients. So this is why we decide to create this registry about treating these patients with percutaneous mitral valve repair with MitraClip. So cardiogenic shock was defined following the SKY classification. In the last years, well, it's quite difficult because if you pick studies from the literature, the definition of cardiogenic shock is quite heterogeneous and depending on the studies. So in the last year, there were kind of consensus from the American Society of Cardiac Interventions, the SKY. They produce a classification based on several stages from A to E with a, let's say, more homogeneous definition with clear relation to the prognosis of the patients. So we asked all the investigators to frame the patients they included in the study in this classification. Since this is something that is not frequently performed, this kind of new use of the device, we created a registry-based study. The population was patients undergoing mitral valve repair percutaneously with the MitraClip device that they presented with acute mitral regurgitation following a myocardial infarction. Most of the myocardial infarctions were ST segment elevation myocardial infarctions. In our series, around 75%, most of them treated by primary percutaneous coronary intervention. All the population was high risk for cardiac surgery. So we did a meeting with the heart team in every center, of course, in every center with their surgeons and their attending physicians. And it was decided that it was too risky for them to undergo surgery. That is so far the standard treatment. So surgical risk was really high. In our series, the mean surgical risk for all the series was 16% in the Euroscore 2 risk scale. That is quite high risk. For those in cardiogenic shock, it was 21%, so super high risk. It's a high risk population. The only exclusion criteria we use is that the attending physicians, the implanting team of the MitraClip, decided the anatomy of the mitral valve was not acceptable for implanting the MitraClip. Apart from that, no other exclusion criteria. So patients were really sick, really high risk, and they were treated with a MitraClip. The key results of this study is that acute procedural success in this type of patients, where the anatomy of the mitral valve can be quite heterogeneous, because you can have mitral valve ruptures, or you can have LV remodeling with tethered leaflets. Procedural success was really high, with the mean procedural success for all the series was beyond 90%, so it's quite high. And the procedure was associated for this type of patients in this clinical scenario with low mortality, low 30-day mortality. Overall series is 6.5% at 30 days. That is really low for this type of patients. Interestingly, there were no difference between those patients in cardiogenic shock and those that were not in cardiogenic shock. Mortality at 30 days for those in cardiogenic shock was 10%, and 2.3% in those patients not in cardiogenic shock. So it's really low, even for mortalities are really low, even for the patients in cardiogenic shock. We saw as well that the acute procedural success that we obtained after the procedure was maintained at 3 months, with a significant reduction in both groups in mitral regurgitation, close to 85-90% with MR less or equal than 2+. There was a huge improvement in functionality. Patients, more than 80% of patients in both groups were in functional class 2 or less. And we assess as well the effect of the cardiogenic shock in the, let's say, long term, that is really mid-term, because the median follow-up was 7 months, in the mortality. And we observed that cardiogenic shock was not an independent factor associated with mortality during the follow-up. The only factor associated with mortality was the procedural success. So this is quite important. This is I will summarize the results as it can be done with low mortality, and the only important thing is select correctly the patients to try to maximize the procedural success. Conclusions for this study is that in this scenario, that is super high risk, the mitral valve repair with the MitraClip is associated with high procedural success and with an acceptable, let's say, mortality and cardiovascular event rates. This is quite important because if these patients cannot undergo surgery, mortality is really high. So now we give another opportunity for them with the percutaneous repair. Another important point, as we mentioned before, is that procedural success is the key for these patients. So the experience of the team, if you have a huge experience in the MitraClip, you can treat more complex valves, more complex pathologies. So if you have success, this is what really will impact the survival and the event rate of the patients. We did not assess cardiogenic shock patients without treatment, because this registry, all patients were treated by MitraClip, and most of them received at least one MitraClip. So we don't have same cohort of cardiogenic shock with acute MR following only medical therapy, but we know the mortality of these patients from literature. In the TCT as well, it was an abstract published, that now the paper is published in the JACC interventions, that we collaborated as well, that is the analysis of cardiogenic shock patients with MR treated with MitraClip. But they perform an analysis where they assessed as well those patients that they don't have success. I mean, probably this represents the mortality of the patients with cardiogenic shock and MR that did not receive treatment. And the mortality for those patients, early mortality in hospital, is 35-40%. So it's 3 times what we achieve in our registry. We have as well an abstract that we presented in the PCR this year, analyzing Medicare data on cardiogenic shock. And we observe as well that those patients with cardiogenic shock that have severe MR and they don't receive any treatment for the MR, mortality is around 35–40%. So, although it's not a direct comparison, what we observe is that with our therapy, we can cut mortality, early mortality, at least 3 times compared to those managed medically. So results of the study for me are quite important because they open a door for those patients that usually are managed medically because the team doesn't believe that they will survive surgery or they are too high risk for surgery. So this is a new hope, let's say, for these patients. But another important point is that the mortality rates we observe are much, much lower than observed in historically surgical cohorts. So this is an important message as well. So this therapy is useful, this therapy is effective, and probably is associated with low mortality. So I'm not saying, because we did not compare to surgical cohorts, I'm not saying that this therapy should be the default strategy, but at least this option, the MitraClip therapy in this type of patients should be considered in the algorithm managing these patients. Next steps for us is to create a new registry with extending this MitraClip in acute MR population and compare them to cohorts of patients treated medically and a cohort of patients, historically cohort of patients treated surgically. Then we can have an idea of how this therapy behaves comparing with the 2 other possibilities. This registry is already performed and it shows interesting results that probably we will see in short time. But I can advance that any intervention is better than medical therapy, and overall, percutaneous repair shows less mortality than surgical treatment. And this is, I think, it's logic because if you see this scenario, MR, it's really important and it's the driving force for the clinical status of the patients, but it's an MI context as well. So in the whole picture, a less invasive strategy probably it's better for the patient. So I think when we release this registry in the next future, it will have a major impact in the managing of these patients.